Hi, I'm Connor, and we're going to talk about stem cells, seen through the lens of erectile dysfunction. The objectives of today are
aging.
And aging. Very important stuff. We're going to start with a brief overview of the landscape of stem cell research, which was completely new to me. Then we're going to dive into some of the animal models used for stem cell research, specifically in erectile dysfunction. We'll look at the design, results, and how they inform possible mechanisms of action. And then we'll look at the small existing clinical studies that exist in this field, which do have significant limitations. And then we'll look forward at the currently registered clinical trials and what we can expect in the coming years. The research I'll be presenting today has limitations. A lot of these are from animal models. The clinical trials are quite small, and we do have a long way to go in terms of establishing safety, cost, and side effects versus alternative erectile dysfunction therapies. But one of the goals for today is to provide context for the results that we'll be seeing over the next 5 years, to show what's been done, and to be able to answer some patient questions which may arise in the clinic about these therapies. At the very least, I hope this will be interesting, and I think that stem cells will be good for something eventually. Whether or not it's erectile dysfunction remains to be seen. I have no specific disclosures. So let's start just by looking at stem cells. These are unique cells with two key properties to them. One is that they're capable of self-renewal and can make exact copies of themselves. This sustains a pool of original stem cells. The second is that they're capable of differentiating into more specialized cell types. They can do this. They can fulfill these two properties by one of two types of differentiation. The first is the asymmetric differentiation, where a parent cell maintains its pool with one division and divides into two, and the other makes a daughter cell. Or you can have stochastic differentiation, where two stem cells will divide, one into two of itself and one into two daughter cells. And this way they can both differentiate and maintain their pool. Stem cells are traditionally classified by how much they can differentiate. And this runs a ladder from totipotent to unipotent. Totipotent cells, for example, a zygote, can differentiate into any cell layer, ectoderm, endoderm, or mesoderm, as well as the extra embryonic tissues. Pluripotent cells can differentiate into multiple layers, but not those extra embryonic tissues. An example would be a blastocyst cell. And then multipotent cells, such as hematopoietic stem cells, can differentiate into any cells within one cell line. The unipotent cell types can differentiate into one cell type, for example, your epithelial stem cells. Because many human diseases rely on or involve damaged or destroyed cells, these properties of stem cells make them attractive for research. People have theorized that they may be able to replicate to replace those damaged or destroyed cells, and there's research going on in a variety of areas ranging from osteoarthritis and diabetes to ALS, and of course erectile dysfunction. There's a significant ethical debate around stem cells, and these debates are often related to the politics of abortion or discussions about human cloning. In Canada, it's currently legal in research to use embryos originally created for reproductive purposes, which are no longer required and without any financial transaction. The US guidelines are similar with some state-specific restrictions. It's definitely beyond the scope of this talk to explore the complex moral and legal issues about stem cells, but I will mention that these concerns center mostly on the totipotent and pluripotent stem cells isolated from human embryos. Research involving stem cells that are present in adults, such as multipotent and unipotent stem cells, skirt these issues for the most part, and so there's increased interest in harnessing the power from these cells. And it turns out that we may be able to reprogram them. Adult cells are typically restricted in their ability to differentiate. They can become themselves or one cell type. But an example of this is fibroblasts, which can differentiate into some subtypes of fibroblasts, but not usually liver parenchyma. But they can be treated in such a way that restores their ability to differentiate into multiple cell lines. A seminal paper in 2006 published in Cell did just this. They took 4 key genes and transfected them into mouse adult fibroblasts using a retrovirus. This caused them to express genes that they wouldn't normally express, and their ability to differentiate changed. Their growth properties matched those of embryonic stem cells, and they expressed some surface markers of embryonic stem cells. When they were injected into nude mice, they developed into tumors containing all 3 cell layers. And for this work, Yamanaka shared a Nobel Prize in 2011. Other researchers have found techniques for stimulating other cell types, such as bone marrow cells, adipose cells, and muscle cells to differentiate into stem cells. Stem cells harvested from these three adult tissues would be easy to harvest in humans. You could aspirate bone marrow from the iliac crest under general anesthesia, sample adipose tissue using liposuction techniques, or harvest muscle with a needle biopsy, although in most of the trials I saw, they were harvesting the muscle during a different type of surgery. So the accessibility or future accessibility of these cells in humans is helping to drive animal research, as it would be more technically translatable should there be positive results in the animal models. The other advantage of autologous procurement is that it reduces the need to step into the murky moral ground, but it has other advantages too. One of the big ones is that it prevents the need for immunosuppression and avoids the negative long-term side effects of immunosuppression, which is especially important in a quality of life disease such as erectile dysfunction. An important safety issue in autologous stem cell, however, is that you can have tumor formation. You've essentially reprogrammed adult cells to renew themselves indefinitely with different growth parameters from normal adult cells, which is a characteristic shared with cancer. One example of this is in a 2011 paper looking at treating mice with diabetes and coronary artery disease. A high rate of mutation and tumor formation was discovered. It was originally intended to be a pilot study for stem cells in an MI and diabetes model, but after injection of stem cells, autologous stem cells into these mice, they started dying off, and autopsy showed that there were tumors in the hearts of the mice and in the hind legs of the mice. The chromosomal analysis then showed that these cells had significant mutations, but none of their surface markers, which were what the surface markers were used to make sure that the stem cells were working, none of those had changed, and so it wasn't detectable on their assays at the intermediate points. This indicates that somewhere in the process of cultivating these cells, there were significant mutations induced. And these safety issues could definitely spell the end of stem cell therapy if anything like this happens in humans. But numerous other clinical studies and animal studies do not show the same dramatic early tumor formation over similar timeframes. It makes you wonder if there might be some technical differences in this particular study. There are also other risks from the culturing process of stem cells, including possible microbial contamination and the fact that the xenographic source of nutritional media for cells, like fetal bovine serum, has unknown effects in humans. These safety issues are all significant and need to be firmly addressed in larger future studies. But in the meantime, other encouraging results drive research for stem cells in many diseases. And one of these diseases, which we'll talk about today, is erectile dysfunction. This is defined in the CUA guidelines as the inability to achieve and maintain an erection of significant rigidity to satisfy sexual activity lasting at least 3 months. It affects 52% of men aged 40 to 70 and is a significant burden on quality of life. The underlying pathophysiology of erectile dysfunction involves many systems, all of which must be working. Traditionally, it's classified into neurogenic, vasculogenic, anatomic, endocrinologic, and psychogenic. But really, most forms of erectile dysfunction have a combined pathophysiology. This particular classification is useful for the framework of animal models and is used broadly to categorize and drive research. Treatment of erectile dysfunction includes a thorough workup and exclusion and treatment of reversible causes of erectile dysfunction. If psychogenic, endocrinologic, or anatomic abnormalities which cannot be easily treated are not present, there are 4 main options. There's oral therapy, injected therapy, vacuum devices, and the more invasive penile implants. Overall, there are excellent success rates, but a common shortcoming of all 4 of these therapy modalities is that they are not disease-modifying. They treat the symptoms, but they don't alter the underlying pathophysiology. The implant is permanent, but it's the most invasive option. And for the oral therapy, injection therapy, and vacuum device, patients need to stay compliant. At 3 years, about 50% of men stop their PDE5 inhibitors. In diabetic and iatrogenic ED, more patients than that even are non-compliant. And these untreated patients open up a potential space for stem cell therapy if it can be safe and administered once or maybe less frequently than the existing modalities. To explore this space, many animal models have been created, and we'll talk about some of the key ones today. The 3 ones we'll talk about are the nerve injury model, encompassing crush injuries or radiation. There's an aging model, and then there's the diabetes model. To start with, we'll look at a paper from 2004 looking at the crush model in rats. This type of stem cell that was used was neural stem cells, which were isolated from rat blastocysts, cultured in modified eagle medium, and transfected with brain-derived neurotrophic factor. This gene was found to induce differentiation into neural stem cells in previous studies. 26 rats were then set up to evaluate the effects of the NES injections. First 5 rats had this sham operation with no surgery, and then the rest had a nerve crush injury, and this was performed by opening the rat's abdomen, isolating the cavernosal nerves, and creating a crush injury with a Kelly clamp for 2 minutes. They then had injection of either a placebo or neural stem cells into either the major pelvic ganglion or to the cavernosa. At 3 months, erectile function was measured using a fairly invasive technique. This was direct nerve electrostimulation. This is where they once again opened the abdomen and stimulated the nerves with electrodes at a set current for 50 seconds. They then measured the maximum intracavernosal pressures with a catheter in the cavernosal bodies directly. A secondary metric was histology, and they harvested penile tissue and stained it for nitric oxide synthase, tyrosine hydroxylase, and neurofilaments. And these 3 stains together gave an idea of nerve density in each of the groups. What we have here are representative waveforms of the cavernosal pressures in each of the groups. The y-axis is the intracavernosal pressure measured in centimeters of water, and the x-axis was time. The red arrows show the time of the start of stimulation. Looking here at the, whatever that is, top right, this is the no injury group, and you can see that there's a waveform with a robust response to intracavernosal stimulation. Over here in the crush and placebo group, that waveform is quite blunted. And again, these are just representative waveforms for each of these groups. This is the group that had the crush injury and no treatment. Then on the bottom here, the crush injury with injection of stem cells into either the major pelvic ganglion or the cavernosa had a partial restoration of that waveform. Overall, analyzing these groups showed that the no injury group had a significantly greatest intracavernosal pressure, but the crush injury groups that were treated with stem cells had more intracavernosal pressure on average than the placebo group. A secondary outcome was the histologic analysis of the corporal cavernosa and major pelvic ganglion nerve filaments. These sections were stained with a blue dye that adhered to the nerves, and the density of the nerves on each side was analyzed. Once again, the findings followed a similar pattern, with the most nerves in the no crush injury group and the least in the crush group that had no stem cell treatment. The stem cells partially restored the fibers compared to the no treatment group, and they did a qualitative analysis with the pathologist, and these nerve fibers were also more qualitatively normal. One interesting finding, which we'll see replicated in some other studies, was that the nerve cells, the stem cells, had been transfected with green fluorescent protein to allow for identification on the stains, but no green stem cells were identified in any section on any rat. This suggests that the stem cells were not acting by direct engraftment into the host, as was initially hypothesized. The next study looked... Sure.
What's your... Why would it work well or better when injecting the cavernosa as opposed to into the ganglia? Which one was the ganglia? Was the left, right?
This is the ganglia, and this is the cavernosa. The waveform looks a bit better for the cavernosa when they analyzed the groups. This particular representative waveform looks a bit better, but when they analyzed the group, there was no statistically significant difference.
Why it would work at all when injected so distally, as opposed to when you think
I mean,
peripheral nerve?
Yeah, I think they were thinking either the peripheral nerves or possibly, because they weren't finding any engraftment, that the stem cells were acting more systemically than they originally thought. Yeah.
What's the time interval after injection to the tracing? Like how long did they wait for the...
This whole tracing from here to here is 50 seconds.
No, but after the injection of the stem cells, how long did they wait before they did the tracing?
In this group, I believe it was 6 months. Sorry, 3 months. 3 months. Yeah. So we're looking at some time, but that and they didn't really justify why they picked 3 months. I wonder if there was a bit of a trial and error with that. But it does show that the effect is present, at least at a longer time after therapy than you would expect from, say, an oral medication. And this next study that we'll look at shows a rat model of ED from radiation. Radiation therapy is often also used for prostate cancer and results in erectile dysfunction in humans in a certain percentage of the time. Destruction of cavernosal nerves and fibrosis of arteries and veins suggests that radiation therapy has a related pathophysiology to cavernosal nerve injury in introducing erectile dysfunction. The type of stem cells used in this study was adipose tissue-derived stem cells. The investigators harvested paratesticular tissue from rats and then went through a protocol to isolate adipose tissue-derived stem cells. This is a previously validated model, but briefly it involves an extended protocol involving collagenase, centrifugation, and cell plating in a stem cell-friendly medium. The radiation model was a 5-day course of external beam radiotherapy directed at the rat prostate. It was 4 gray per day at the prostate for 5 days, and then a week later, the rats had injected into their tail veins either a control phosphate buffer solution or adipose tissue-derived stem cells. 11 weeks later, they had 5 more days of radiotherapy, and then erectile dysfunction was evaluated 6 weeks later in a similar manner to the previous study, once again with direct cavernosal nerve stimulation and intracavernosal pressure measurement. One nice touch that they had in this study, and it was about 8 years later, is that they normalized the intracavernosal pressure to the mean arterial pressure for each of the rats to help to control for any differences in systemic blood pressure. And once again, a secondary outcome was histology, looking at nerve fibers. This graph shows the key finding from the study, and on the y-axis here we have the intracavernosal pressure over the mean arterial pressure. The x-axis, they use different amperages, 3 different amperages, as kind of a dose-response curve, I guess. And each of the colored bars represents one of the groups. The blue bar is the control bar, who received no treatment and had no radiation. The red received radiation and had control solution injected into the cavernosa. And the green had radiation and then received an injection of stem cells. And you can see that at each of the amperages, those rats with no stem cell treatment had the least amount of, or least intracavernosal pressure, and that the green was not significantly different than the blue, showing that the stem cells helped to restore intracavernosal function even after that radiation treatment. Once again, the histology findings were similar to the last slide, showing better nerve staining in the stem cell injection group, but could not find any evidence of engraftment, although they didn't look for it specifically. Here they are, looking at the histology. The last rat study we'll look at with cavernosal nerve injury provides a bit of a new slant on mechanism. The setup of the rat model is now familiar. They used adipose-derived stem cells. They had a similar crush injury model. I think this time they used a different kind of clamp. And they took 32 rats, divided them into 4 groups, and one group had a sham operation with no injury, one had the control injection, one had the stem cell injection, and one group had a lysate of stem cells, which was obtained by incubating the stem cells as per usual, and then putting them in ionized water to let the membranes break down. 4 weeks later, they measured the intracavernosal pressure in a similar fashion to the other studies with direct nerve stimulation, and they also used the ICP to MEP ratio, which seems like it became the new standard. Secondary outcomes were histologic and included staining for nitric oxide, smooth muscle, and apoptosis in the corpora. This graph shows the key finding, and once again our y-axis is the intracavernosal pressure over mean arterial pressure, and we have each of these bars represents one of the 4 groups. The sham group is the no injury, no treatment group. The vehicle is the nerve injury with control injection. And then here we have injury with stem cell injection and injury with lysate injection. The most interesting finding here is that both the stem cells and the lysate groups are equal, and they restored some erectile dysfunction over the no treatment group, although they weren't as much as the no injury group. Histology was a secondary outcome, and once again there was increased nerve present after treatment with either lysate or stem cells compared to the vehicle, with less fibrosis and better preservation of smooth muscle content in the stem cell and lysate groups. The authors hypothesized here that it was neurotrophins, molecules that stimulate nerve growth and regeneration, such as nerve growth factor, TNF-alpha, and VEGF, and maybe other small molecules yet to be discovered that may be the real contributors to nerve regeneration and partially restored erectile dysfunction, rather than the stem cells themselves. This brings us to the two main theories of stem cell action. And originally it was hypothesized that stem cell therapy was mostly acting by engrafting into the host and differentiating into the required stem cell type. And this was the theory that stem cells would be influenced by the environment in which they were placed. The environment's need for a certain type of cell would cause them to differentiate to replace missing or defective cells. But more recently, as we've seen in the last 3 studies, evidence has emerged that turns this theory on its head. Stem cells may actually influence the environment by paracrine activity. And in this theory, stem cells are releasing molecules and signaling factors into their environment that alter the activity of the cells around them, but do not actually engraft into the area. The previous rat study on injecting lysate into the cell supports the paracrine theory, as lysate was as effective as the cell injection themselves. And this also explains why we've been finding not much evidence for engraftment of the cells into the host. Using lysate in the future in humans may have some safety advantages, including decreased risk of tumor formation. But some other studies in animals have found small amounts of stem cells in erectile tissue after injection, and the duration of effect of lysate versus stem cells has not been established. But it does present a promising possibility. The cavernosal nerve injury model in rats attracts a lot of animal research, partly because it's a fairly easy model to create. But as we touched on, there are other large categories of erectile dysfunction. And another type of these is aging, which we can replicate in an animal model, highlighted by this paper. It's from the British Journal of Urology from 2008 and provided the template for aging model studies. This particular study used muscle-derived stem cells from mice. And this is because in mice they've been previously validated, despite the fact that they later had to use rats for the rest of it. They aged their rats for 20 months, and they had 3 groups, saline injection and stem cell injection measured at 2 and 4 weeks with erectile function, with the outcomes, once again, the familiar intracavernosal pressure and histology and Western blot. The x-axis, or the y-axis here, was the mean intracavernosal pressure over map, with each of these bars representing one of the groups. The maximum intracavernosal pressure for the black bar is the rats who were aged and received saline. The pink bar was 2 weeks, who received stem cells and had their erectile function measured 2 weeks after injection. And the third bar is at 4 weeks after injection. And this just helps to show that the effect of the stem cells may not be durable, that it may not be a one-and-done kind of treatment, but that it does decay over time. One possible confounder in this study was that tacrolimus was given to the teal and the pink groups, but not to the saline rats. One final model of erectile dysfunction is in animals that we'll look at today is the diabetic model. In these studies, rats are injected with streptozotocin, which is toxic to pancreatic beta cells, and 6 weeks later they have diabetes. It's a well-validated model of diabetes in rats. I'll give you some highlights from a couple of the studies. And their basic outline is very similar to the previous studies that I've talked about, so I won't go through the methods in detail, but here are a couple of highlights in the findings. First is from 2012, which found an increase in intracavernosal pressure after injection of adipose tissue-derived stem cells. This was at 4 weeks after injection. One of the interesting parts of this study was that the effect was reduced when the gene for adrenomedullin, which is a known vasoactive peptide, was knocked down in the stem cells with silencing RNA, potentially implicating it in the mechanism. Another key study in this model was published in PLOS1 in 2013, which found that adipose-derived stem cells significantly improved erectile dysfunction at day 7 and 28 after injection. Another group injected with adipose tissue-derived stem cells that were modified with a lentivirus to increase their VEGF secretion improved erectile dysfunction better than those that did not have this upregulation, which once again points to an angiogenic mechanism. The histochemistry confirmed improved endothelial nitric oxide secretion, endothelial marker expression, and smooth muscle marker expression in those treated with the stem cells. But once again, no stem cells could be found in the engrafted tissue. And finally, another study found that an injection of media that was exposed to bone marrow-derived stem cells improved erectile function in diabetic mice versus the stem cells themselves. This is similar to that previous Lysate study that we looked at, but one of the differences from this is that the effect was not as strong as the stem cell injection themselves. So overall, from these chronic models of erectile dysfunction, we found that there's fairly weak evidence for engraftment of the cells into the host tissue, that VEGF and vasogenic molecules may play a role in the regain of erectile function from injection of stem cells or lysate, and that stem cell exposed culture media improves erectile function. Unfortunately, the complexity and heterogeneity of the chronic erectile dysfunction models, which involve neurogenic and vasculogenic etiologies, makes the mechanism hard to clarify completely. So there are still many basic science questions left to be answered, such as which stem cell type, the long-term safety of each of the stem cells, and cell lysate or whole cells should be used. And finally, we have to figure out what the specific mechanism of action is. One other important issue is whether or not any of these studies will translate to humans. At this point, there's these papers that I picked out kind of have interesting or unique takes on this question, but there are quite a number of rat studies that have showed positive effects for erectile function with either stem cell treatment or lysate treatment. And this kind of sets the stage for our translation into humans, and we'll go over a few of the clinical trials that are done and what are in progress. If you look through your spam, you'd think that stem cell therapy for ED is already here, and it's something that you may get asked about from patients occasionally. We'll go through the 4 published clinical studies that are out there and examine what's been done, and these are very small and low-impact clinical studies, but help to set the stage for future tolerance and safety profiles. The first came out of South Korea in 2010, and this study recruited 10 patients who had type 2 diabetes. Despite the use of oral medications, they had not had an erection for longer than 6 months. They were all awaiting penile prostheses, had to have a BMI between 20 and 25, and had to undergo extensive testing to exclude other diagnoses, including blood panels, tumor marker panels, EKGs, and both gastroscopy and colonoscopy. Patients with any of these abnormalities, including abnormal testosterone, were excluded. The baseline clinical information included demographics, history, physical, duplex ultrasonography, and International Index of Erectile Function score, which was a 5-point score of erectile function. Each question was scored out of 5. These patients were then pseudo-randomized by the order of recruitment. They'd take 2 into the experimental arm and 1 into the control arm, and this yielded 3 controls and 7 experimental patients. The intervention was single-blinded. They used human umbilical cord blood stem cells, and these were obtained from a company specializing in isolating these cells from donors, matched by blood group, sex, and HLA type 1 and 2 for each recipient. These cells were then injected into each corpora while the penis had a rubber band placed around it, and it was left there for 30 minutes. The control group received saline. No group received any immunosuppression. They followed up with these erectile function questionnaires, an erection diary, and secondary endpoints included a blood sugar diary and a medication diary. They're kind of doing a 2-for-1 with erectile function and diabetes. Patients were allowed to use PDE5 inhibitors starting 3 months after the stem cell injection. So for our results, the age range was 57 to 87, and all the patients had a pre-stem cell reduced peak systolic cavernosal velocity. Between 3 and 9 months, which was the time of the study, 6 out of 7 patients in the intervention group reported an increase in frequency of erection. This was encouraging at first, but it's kind of hard to read too much into studies with such a small number, and also these were changed from a 1 on the questionnaires to a 2 or 3 on the questionnaires. There was no change in any of the control group for any of the questions except for sexual desire. Of course, this being a single-blinded study, it makes you wonder if there is the patients weren't picking up on unintentional cues from the experimenters. The secondary metric of diabetes medication use was interesting, as the hemoglobin A1C levels were reduced by approximately 1 in the interventional group versus the controls. What I was most interested in was the adverse events, and there were no adverse events reported, although the authors did not specify their collection method for adverse events. The conclusions were overstated somewhat in this study, indicating that stem cells had a positive effect on both diabetes and erectile dysfunction. It's encouraging to me that there were no major adverse events, such as rampant tumor growth or death, and that's what I think the main utility of the study was.
How do they prepare the stem cells from the corpora? They just isolated them and instilled them, or did they give them growth factors?
For this specific isolation, it was a little bit opaque because it was obtained from a commercial company, so they didn't share all of their methods, except that they get the stem cells, they're supposed to be isolated, and they're expressing all the appropriate markers. But I see what you mean, that, is it...
It's hard to imagine that you just put in stem cells into these cavernosal bodies and it doesn't act.
Yeah.
You have to program to be somewhere.
Yeah, for sure. I think looking at this, there were kind of two theories to it. Either it's possible that the stem cells the media contained some of those angiogenic factors that were used in stem cell growth, and it was confounding the results. Or it's possible that the area of insult, that the penis or the systemically the diabetic problems were signaling to the stem cells what they need. I think it's possible that the body itself is kind of programming the stem cells to meet their needs, but I think there are a number of confounders that could be alternative explanations for sure.
Name another system in which stem cells applied has grown into what you want it to grow without programming.
I mean, I'm not familiar with a lot of the evidence from the other systems that they're looking at, but I think they have had positive results in a number of the different models, like here.
I guess the other extension of that, and not to hijack where you're going, but you're taking stem cells out of the blood
Mm-hmm.
and then just concentrating them in the penis.
Yeah.
But if you got stem cells in the blood, and your body's being told that they're needed in the cavernosa, why are they not just being recruited from the blood?
Yes. Yeah, that's fair enough. I guess one possible mechanism would be that the body needs a little jump start in order to help create an increased concentration of stem cells. But yeah, that's certainly something to consider. To touch on some of the other areas where stem cells are being looked at is bone, cartilage, heart, neuro, diabetes, and lung models have all shown some good results in stem cell injection. And so there are a number of other systems that have shown these results as well. It's not specific to the penis. So that's the first study, first of 4. The next was a study published in the European Journal of Urology several years later, looking at a phase 1 dose-escalating safety evaluation, and this time of bone marrow stem cells and injection after prostatectomy. It was inclusion criteria were men 45 to 70 who underwent radical prostatectomy from 6 months to 3 years earlier with localized non-aggressive prostate cancer. P&L hardness had to be insufficient for penetration, even with pharmacotherapy. And then the bone marrow stem cells were collected by aspiration of bone marrow and followed by centrifugation and incubation methods, and were injected the same day as harvest. Tourniquet was applied to the glands of the penis, and stem cells were injected into the cavernosal bodies. The tourniquet was removed after 5 minutes, and there was no control group. The primary endpoint was adverse events, appropriately within 6 months. 1 month, 3 months, and 6 months follow-up visits were performed, and the secondary endpoint was looking at International Index of Erectile Dysfunction, Erectile Hardness Score, penile length, and penile vascularization. They also used a metric called the P-Nort, which is the penile nitric oxide release test, looking at cavernosal artery diameter before and after application of a sphygmomanometer. I don't know if that's been very well validated, but they also looked at peak systolic velocity and end diastolic velocity and resistive indices. First, they took 3 patients and provided them with 4 escalating doses to ensure that there were no adverse events. And although they did not provide information about how long they followed those 3 patients for, lack of adverse events permitted them to proceed with the study with an additional 12 patients. These patients were divided into 4 groups and received one of the dose concentrations of the bone marrow-derived stem cells. Once again, no control group. Mean age was 64, plus or minus 4 years, with mean time from radical prostatectomy to injection of 22 months. All patients had pain, and 3 out of 12 patients had bacterial contamination, which resolved after modifying of their technique. But there were no clinical effects such as abscess or fever in the contaminated patients. There were also no major adverse events such as cardiovascular events, emboli, or death in any of the patients. The secondary outcomes were once again encouraging, with gains at 6 months in the erectile hardness score on and off medication by approximately 1 point, and a 10-point gain on the International Index of Erectile Function subscore. Of course, once again, not a placebo-controlled trial, so it's entirely possible that these patients would have had improved erectile function regardless as a result of the natural course of recovery after radical prostatectomy. Unfortunately for all of us, penile length did not improve after stem cell treatment, and the penile nitric oxide release test, defined as a positive cutoff in greater than 35% of patients, was positive for 8 out of 11 patients. Once again, this could all be due to the natural history post-radical prostatectomy. The next article was from a small journal, and I'll just go over it briefly, that there were 8 patients recruited from a private practice in Florida. It was unclear what the inclusion criteria were other than erectile dysfunction and willingness to participate in the study. Placental matrix was then sampled from consenting donors and produced mesenchymal stem cells with multipotent potential. These were then injected into the cavernosal bodies, and follow-up data on similar endpoints was collected at 6 weeks, 3 months, and 6 months. No serious side effects were reported, although those were not the primary endpoints. Their primary endpoints were peak systolic velocity, end diastolic velocity, penile length, penile width, and a function questionnaire. No statistically significant difference in the ultrasound or survey scores was found, but 3 out of the 8 patients became able to sustain erections without oral therapy when they were unable to do so previously. Once again, no firm clinical conclusions could be reached from this study. And the last completed clinical trial was just published in January, coming from a group in Denmark. In it, they took 17 men who just had radical prostatectomy, who failed conventional therapy and were enrolled. They had to be older than 18, sexually active, and pre-radical prostatectomy, and have erectile dysfunction, which was refractory to oral medical management. The stem cells were freshly derived autologous adipose tissue-derived stem cells collected from liposuction, isolated and injected into the corpora cavernosa, and no control group. Primary outcome was adverse events, and this was followed by more specific. They very clearly outlined how they did that, asking, did you experience any discomfort related to the operation since the last visit, followed by more specific questions. Secondary outcomes were the International Index of Erectile Function, Erectile Hardness Scale, and the Incontinence Questionnaire, and these outcomes were assessed at 1, 3, and 6 months after injection. They identified 57 patients who were identified and interviewed at routine sexual rehabilitation following up from radical prostatectomy, who were not responding to medical management. 39 patients were excluded for various reasons, such as recurrence of prostate cancer, progress in erectile function, or logistical problems or lack of fat. 4 were excluded for illness. And amazingly, of the 18 patients who fulfilled the study criteria, only 1 chose not to participate. The median age of the patients was 63, and the median time post-radical prostatectomy was 10 months. once again introducing the natural recovery of erectile function post-radical prostatectomy as a possible confounder. 8 out of 17 patients recovered sexual function, defined as the ability to complete intercourse with or without medication, and there were 5 minor adverse events after the liposuction, including redness at the sites and 1 scrotal hematoma which resolved spontaneously. 2 patients had abdo pain, and all events resolved at 3 months. One nice touch that they had on this study was that in a review of their department's record, the spontaneous recovery of sexual function was expected to occur in 26% of the patients at that center in 6 months. It was an attempt to provide a bit of a comparison and context, although the lack of a formal control group is still a limiting factor. But it showed that 47% versus 26% could easily be a sampling bias. A secondary metric was that the investigators also found that there may be an effect on increased continence via a continence questionnaire, showing that stem cells have multiple applications, even in urology.
What it shows is that the results are independent of the intervention.
Yes.
You can't, it's like, there's no way link changes in. I mean, it just illustrates the problem with interpreting effects of a treatment and outcome with such a trial design.
Mm-hmm. Yes, yeah, it definitely has some serious limitations with the lack of controls. There are a number of ongoing clinical trials. 14 are registered in the clinicaltrials.gov website in the U.S. 2 are withdrawn, 1 was completed, and the rest are in active recruitment or data collection. The largest urology-specific ongoing trial opened in 2014 and is hoping to recruit 100 patients, still in the recruitment phase. And they will use adipose tissues in an open-label, non-randomized trial for men 18 to 80 with arterial insufficiency or venous leakage documented on Doppler, excluding men with other serious medical illness. And primary outcomes will be their 5-point penile hardness scale, and throughout the study, patients will be followed for adverse events. Estimated date of completion is December 2017. There are 12 other registered trials specifically for erectile dysfunction, ranging in size from 8 to 50 patients. Most have safety as a primary outcome, with a couple looking at duplex ultrasonography parameters or hardness scores, and we will expect to see these emerging in 2017 to 2018. And one very important study that will open up future trials, if there aren't many adverse events, has 3,000 participants and is looking at overall safety of stem cells across a number of fields. Just for fun, I included some of the findings of the recent AUA meeting showing where we are right now. Interestingly, most of the presentations with the keyword stem cells were from the oncology world, looking at cancer stem cells, which are somewhat of a different beast. But nevertheless, the true stem cell research spanned urologic fields, from enhancing kidney transplants with stem cells to using them in reconstruction of urologic strictures. In fact, stem cells had its own session this year. So we'll just go back over our objectives. We looked at a brief overview of stem cell research landscape, went over a couple of the animal study models, cavernosal nerve injury and the chronic models of erectile dysfunction. And we looked at the small resulted trials of stem cell therapy and the planned upcoming clinical trials. Overall, we're not sure if stem cells will really provide that magical on switch for erectile dysfunction that we've been looking for. But we'll expect to see some more phase 1 and 2 clinical trials emerging in the next 3 to 4 years. And I hope that this talk has provided some context for those results. And even with their severe limitations, it's helpful to be able to give something back to patients if they should ask about these studies in a clinic. I'd like to thank Dr. Gerald Brock, Ryan Flanagan for helping me come up with the idea, and Dr. Mark Nagarall for their contributions.